Welcome to this learning session on bacteriological diagnosis of tuberculosis. I will be dealing with smear and culture examination for Mycobacterium tuberculosis in this learning session. I am Dr. Shivakumar from the Department of Bacteriology at ICMR National Institute for Research in Tuberculosis. The importance of diagnosis was emphasized by our father of nation, Mahatma Gandhi ji, who said a correct diagnosis is 3/4 a remedy. Now, diagnosis of tuberculosis can be of different types and can be done by either clinical findings, radiological findings, or bacteriological findings. And bacteriological finding mainly is by direct demonstration of causative agent as a whole or its component, as a whole by smear or culture, or by its component by nucleic acid detection. Growth characteristics, that is growth rate or growth temperature, can also be used for detection or bacteriological classification of organism, and bacteriological classification of organism can also be demonstrated by metabolic products like pigments and different enzymes which are produced by the Mycobacterium tuberculosis or other species of Mycobacterium. To be an ideal test for TB diagnostics, we require the following things. It should provide an early and accurate diagnosis, that is, it should be rapid, also very sensitive and specific. It should be very simple to be performed by a lab technician. It should be reliable and it should be very cost effective as well. Now, apart from the above general requirements, specific requirements include it should be capable of discriminating between infection and a disease. It should also discriminate between a live bacilli and a dead bacilli. It should discriminate between Mycobacterium tuberculosis complex and non-tuberculosis Mycobacterium. It should also differentiate between a drug sensitive and drug resistant tubercle bacilli. A good quality sputum is prerequisite for good diagnosis. For a pulmonary tuberculosis, sputum is the best sample for diagnosis. Apart from this, gastric aspirate can be collected from pediatric patients who are unable to give sputum samples. There are several types of samples which are collected. Saliva is not suitable for diagnostics for TB. Best suitable sample is mucopurulent sputum sample. Blood mix sample can be used for smear and culture, but it is not suitable for molecular diagnostics. The sputum collection, sputum also needs to be transported to the respective laboratory in proper manner. So, the sputum should be collected in a leak proof container with clear labeling of the patient's identity, and then it should be transported along with a request form. Now, if there is a delay which is expected beyond 72 hours, then the sputum should be transported in a cold chain between 4 to 8 degrees, and when the sputum has to be transported through a courier, a triple packing mechanism has to be is mandatory for all the samples which are transported. Now, before transporting, gastric lavage which has been collected has to be neutralized using bicarbonates, and if a tissue sample in case of extrapulmonary tuberculosis is transported, it should be transported in saline or buffer and never in formalin. Now, we will look at triple packing of infectious material. Triple packing of infectious material has 3 containers. The first container or the primary container is the primary receptacle, and it is a screw cap tube, and this, once the sputum is transferred into the screw cap tube, after screw capping the tube, we need to seal it with paraffin. This paraffin sealed tube goes inside a Ziploc cover. Now, this Ziploc cover should have enough absorbent material to absorb the liquid material which is present in the cryo vial. This Ziploc cover has to be placed in a secondary container, in which along with this sample, the laboratory information sheet has to be placed, and this has to be placed in a separate Ziploc cover. Now this container goes inside the tertiary container or the third container, which is maintained at 2 to 8 degrees using a gel pack. Now, now we'll go on to the conventional bacteriological diagnostic methods, and for TB, and the methods include smear microscopy and culture, and the culture can be by solid culture or by liquid culture. Now, looking at smear microscopy, it's the oldest technique for diagnosis of tuberculosis, and it's almost a century old technique, and this is a basic diagnostic tool or a screening test for Mycobacterium tuberculosis. The advantage is it requires minimal infrastructure, it's very simple, it is inexpensive, it is quick, suitable for any type of specimen like sputum, pus, CSF, gastric, aspirate, biopsy, and so on. And it is available in all levels of laboratory, starting from the lower district microscopy center to the reference laboratories. Now we will go into the appearance of TB bacilli in acid-fast smears. There are two popularly used methods. A bright field microscope uses Ziel-Nielsen staining, whereas fluorescent microscope uses Oramin phenol staining. In the bright field staining, the background is blue and the bacilli appears pink, are popularly known as pink stained long slender beaded bacilli, whereas in case of fluorescent microscopy, it is yellow, bright yellow stained and the background is dark. Now, smear microscopy is a semi-quantitative way of measuring the amount of TB bacilli present in any sputum sample, and it gives an estimate of bacterial load and degree of infection at diagnosis, and gives an estimate of patient's response to the treatment and status of cure when patient gives a serial samples from baseline and till the treatment ends. Semi-quantitative way of measurement is done using the following table, which is released by WHO. Here, one length of a smear is approximately 2 centimeters and measures around 40 to 50 fields. If we don't see any bacilli in one length of smear, then it is called as negative. If you see around 1 to 19 AFB or the bacilli in one length, it is called as scanty. When you see 20 to approximately 199 AFB per length of smear, it is 1 plus, and 2 plus is 5 to 50 bacilli per field on average, whereas 3 plus is greater than 50 AFB per field. Now, although smear microscopy is easier to perform, gives quick results, as well as can be performed on a DMC level, it has its limitations, and the limitation is the sensitivity. It has a low sensitivity, which is approximately 55% by using from various studies, and it is still lower in cases of HIV patients. Although smear microscopy is best suited method for peripheral health centers and gives quick results and does not require trained people, there are limitations to it, and the limitation is lower sensitivity. It's up to 55% and it is lower in case of HIV patients who are infected with TB. The limit of detection is somewhere between 5,000 to 10,000 bacilli per ml, and which makes it unsuitable for paucibacillary specimens, which are mostly extrapulmonary specimens. Now, it cannot distinguish between Mycobacterium tuberculosis and non-tuberculosis Mycobacterium. It cannot differentiate between dead and live bacilli. Of course, it cannot differentiate between drug sensitive and drug resistant bacilli. Now, it does require some amount of skill to avoid false positivity and false negativity, and it is partially unsafe until it is stained, as there is live bacilli sitting on the slide. So, it is hazardous to health workers as well. Set the limitations, we have some improvements in the microscope, wherein the new microscope which is released is called light emitting diode microscope, and advantage of this microscope over previous fluorescent microscope is it is less expensive, consumes less power, and can run on batteries. The bulb which is used for iLED microscope has a longer shelf life and does not pose any risk of toxicity when it is broken, and the main advantage is it does not require dark room as compared to fluorescent microscopy which is done before. So, with this background, WHO has recommended replacement of conventional fluorescent microscope and Z-Nielsen light microscopy by iLED microscope. Now, after microscopy, its culture. First, we will deal with solid culture, and solid culture is mainly done on egg-based medium, and this medium is popularly known as Lowenstein Jensen medium. Now, moving on to culture-based methods. First, we will deal with solid cultures, and solid cultures are egg-based cultures, and there are some agar-based medium as well. The popularly used LJ medium is egg based, and LJ is Lowenstein Jensen, the discoverer of the medium. Now, it provides a definitive diagnosis. It's still a gold standard for diagnosis of tuberculosis. It is suitable for all the samples, but requires decontamination to eliminate common contaminants which are present in the flora of sputum. Um, the limit of detection is much lower, 10 times lower. It's around 1000 organisms per ml of sputum. The other advantage of solid culture is the strain is available for drug susceptibility testing and strain typing as well. Now, we will look at the morphology of this organism, Mycobacterium tuberculosis, on this culture. So, the morphology is popularly known as rough, buff, and tough. So, buff is color, it is off white in color. Rough is the texture of the colony is rough, and they are tough to be emulsified in a liquid medium. So, this is the popularly used LJ medium, and it shows a growth of Mycobacterium tuberculosis. Solid culture is also a semi-quantitative measurement of the load of bacilli. So, in this you can see that depending upon the number of colonies which are present, it can be classified into 1 plus, 2 plus or 3 plus. If the number of colonies are 1 to 9, we have to report only the number of colonies, that is, if there are 5 colonies which on the LJ medium, you report it as 5 colonies grown in culture. If it is anything between 10 to 100 colonies, you report it as 1 plus. If it is 100 to 200, but it can be countable individual colony on LJ medium, it is it will be labeled as 2 plus. And if it is a confluent sheet of growth which is shown in this picture, is 3 plus. Now, although it is a gold standard, this also has some kind of limitations, as the TB bacilli grows very slower in solid culture, and this can take up to 8 weeks. So, the diagnosis is delayed by 8 weeks. It requires skilled person to prepare the medium, to have a sample processed and inoculated, requires infrastructure for handling this culture and processing of the culture. So, it is not suitable for resource poor setting. It requires a BSL-3 facility, so only reference laboratories and high-end private laboratories can perform solid culture using Lowenstein Jensen medium. Now, apart from this, cross contamination leading to wrong diagnosis is a remote possibility. Now, apart from the growth seen on the LJ medium, we need to do additional test to confirm the growth to be Mycobacterium tuberculosis. Next, we will come to liquid culture, and liquid culture can be done either by manual or automated methods, and the popularly used method is BACTEC MGIT960, which is an automated method. The BACTEC MGIT960, which is automated method, has a capability of simultaneously looking at around 960 tubes. It has 3 draws, each draw holds around 320 tubes. Now coming to the features of the MGIT960, which is a popular method of liquid culture. It is by Becton and Dickinson, and it's a commercially automated system, and it has modified 7H9 medium for its growth, and it can hold up to 960 tubes at any point of time. So the advantage is auto measurement, wherein the machine measures for the growth of Mycobacterium every hour, and this is a software based methodology. It is useful for all the sample except for blood and urine. Now, what is the principle behind this MGIT960 or MGIT tube, which is called as Mycobacterial Growth Indicator tube? So, it has a barcoded tube, and this barcoded tube has 7 ml of medium, and when it is inoculated along with growth supplement and antibiotic supplement to prevent the growth of normal flora which are present in sputum. So, this 7 ml medium contains fluorescence quenched oxygen sensors. So, oxygen is present in the 7 ml of medium, and which quenches the fluorescence. So, when there is utilization of this oxygen, when a particular microorganism grows, this fluorescence is released. So, once the fluorescence is released, at every reading which is done every hour, we can detect the growth. So, once a particular threshold is reached, the tube turns positive, but we cannot take this positive as Mycobacterium tuberculosis growth. So, we need to confirm it. Now, this confirmation is done by AFB staining and immunochromatography. The total growth period allowed is 42 days. That is, to call a sample as negative, it will require 42 days, but any positive sample can go up to from 5 days to 42 days. So, it is useful for both TB diagnosis as well as for drug susceptibility testing. Now, we will come to identification and confirmation of MTB growth, which is done by AFB smear and staining using Nielsen staining and immunochromatographic method, which is for detection of MPT64 antigen. In AFB staining, we use Nielsen staining to look for cord formation, and immunochromatographic method involves use of this liquid culture. The immunochromatographic method has antibodies, gold coated antibodies on to the chromatographic strip. When we pass the liquid culture through this strip, if we have MTB culture, then this will bind to the antibody containing gold conjugate and give a pink color band. The immunochromatographic strip also has inbuilt control, positive control. Both the bands should appear to call it as Mycobacterium tuberculosis complex. This BACTEC MGIT960 result output is shown here. There is a lot of data here which includes the patient's identity, the tube number and so on. But the most important thing here is the growth unit, which is based on the fluorescence which has been measured, and then time to detection, TTD. Time to detection is labeled in days and hours. Now, what are the advantage of MGIT over the previous diagnostic tests which have been described here is it can do both diagnosis as well as drug susceptibility testing. It has high recovery rate in less time because the culture medium is liquid. It has higher sensitivity over solid. Um, there are growth supplements to enhance growth. That is why we get earlier growth compared to solid medium. And of course, this method also has some amount of disadvantages, that it requires BSL-3 as for the solid culture, as there is high risk of aerosol generation. This is a liquid culture, that is why, and it is expensive since it is a commercial medium, and requires the machine, the MGIT960 machine requires continuous power supply and air conditioning, and since it is a liquid culture, there are higher rates of contamination if the environment is not decontaminated properly, and though the growth needs to be confirmed using AFB microscopy as well as immunochromatographic method. Now we will come to a different arena, which is non-tuberculosis mycobacterium, or popularly known as NTM. Apart from a Mycobacterium tuberculosis complex, Mycobacteria has other species of Mycobacterium which are also important for identification and for the treatment of a patient. Now, most common methods for identification of NTM include smear, which includes the colony morphology, and they can be colored or pigmented, or they can be slow grower or rapid grower. So, that is why it also can be identified using growth rate, pigment production, optimal temperature. Then there are biochemical tests specific for Mycobacterium tuberculosis and non-tuberculosis Mycobacterium. We can also identify non-tuberculosis Mycobacterium by high performance liquid chromatography. There are molecular methods which are available like line probe assay. There are commercial kits which are CM and AS kit by Haynes. This identification of non-tuberculosis Mycobacterium can also be done by MALDI-TOF, which is a spectrometry method. Now, this is identification of non-tuberculosis Mycobacterium in culture. They appear in different shapes and size and texture. For example, M. fortitum on an egg-based medium shows a donut colonies, whereas M. schulgi on egg-based medium shows a smooth dome-shaped colored colonies, whereas M. marinum shows irregular pale yellow pigmented colony, and so on. Now, species identification of NTM can also be done by biochemical tests. The first test is by niacin production. Niacin is positive for Mycobacterium tuberculosis, whereas negative for non-tuberculosis Mycobacterium. Next test is nitrate reductase test. This is based on the enzyme which is produced, nitrate reductase, by Mycobacterium tuberculosis. Mycobacterium tuberculosis is positive for nitrate reductase, whereas non-tuberculosis Mycobacterium is negative. So, there are other tests like aryl sulfatase, which differentiates between Mycobacterium tuberculosis and non-tuberculosis Mycobacterium, and there is heat stable catalase test which also differentiates between the Mycobacterium tuberculosis and non-tuberculosis Mycobacterium. Now, the other method of identification at species level for Mycobacterium is high performance liquid chromatography, wherein in this method we extract the mycolic acid which is present on the cell wall of Mycobacterium, and this is subjected to high performance liquid chromatography, and we get peaks as you see in this pink peaks are seen, and each organism has a peculiar signature of peaks, and this is identified based on those peculiar peaks at peculiar time point. The next method of identification is by MALDI-TOF, which is known as matrix assisted laser desorption time of flight mass spectrometry, and So how it is determined? It is a unique proteomic fingerprint of a particular organism. This can be used for other organism as well, like other microorganisms. So for Mycobacterium tuberculosis or other non-tuberculosis mycobacterium, there is a mycobacteria library which covers around 178 of the 201 mycobacterium species present, and it's the most um, species level discriminatory test which can be done to determine the species level discrimination of non-tuberculosis mycobacterium. There are several molecular tests also available for differentiation of non-tuberculosis mycobacterium. Um, this may be gradually replace the conventional methods of identification, differentiation, and resistant detection. So, this molecular test include a line probe assay, PCR RFLP or real-time PCR and DNA sequencing, and also whole genome sequencing. Now, this not only will help in identifying the mycobacteria and drug resistance prediction, but it also facilitate the analysis of outbreaks and track transmission patterns in the community for non-tuberculosis mycobacteria. Now, this is the first test, which is genotype CM test. This can identify up to 20 non-tuberculosis mycobacterium based on the banding pattern, which is here. Uh, each banding pattern is very peculiar for a particular organism, and this can be directly done on sputum sample. The next is genotype M Mycobacteria AS, which can be done only on culture, and this can also identify same organisms or 20 non-tuberculous mycobacteria apart from Mycobacterium tuberculosis. Now, apart from the species level identification by this kits, this kits can also be used for drug resistance prediction for particular non-tuberculosis mycobacterium. Now, non-tuberculosis mycobacterium has to be identified to species level, as each species might differ in treatment for the patient. Now, this slide shows about the polymerase chain reaction RFLP for HSP65 gene. This can also classify close to around 10 species of mycobacteria. Now, the ultimate tool is whole genome sequencing. So, this can be cannot be directly done on sputum, but can be directly done on the culture, which is available either from liquid medium or solid medium. So, WGS can be performed routinely in high throughput laboratories only, and this has high agreement with the current diagnostic method, and for both it can be used for mycobacterial species identification and drug resistance. Now, apart from identification and drug resistance prediction, it can also be used to track transmission patterns in the community, thus helping in finding out outbreaks of non-tuberculous mycobacterium in hospital setup or in any community setup. So, with this, we almost come to an end of our session. So, the key messages from this session include that smear is a very simple method for diagnosis of tuberculosis. It is rapid, it is inexpensive, but has lower sensitivity, and the cost for smear examination by using fluorescent microscopy or Nielsen method will vary between 50 to 100 rupees. Culture is still a gold standard for diagnosis of tuberculosis, which includes solid culture, which has to be done in house. It requires BSL-3 facility. It is time consuming. It is labor intensive and cost around 150 to 250 rupees per sample. Liquid culture is rapid compared to solid culture, but requires special infrastructure and an automated instrument, and this can cost between around 350 to 500 rupees. So, both this solid and liquid culture requires additional tests to be confirmed for whether it is Mycobacterium tuberculosis or non-tuberculosis mycobacterium, or for drug resistance and drug sensitive strains. So with this we come to an end. Thank you, and thank you for your kind attention.